My name is Arvind Pandey. I am faculty at School of Public Policy and Governance, Tata Institute of Social Science, Hyderabad. On behalf of our school, I welcome you all in our 63rd prospective lecture. We are organizing a series of webinars as part of our prospective lecture series under a broader theme, which is After COVID, Imagining New Socio-Economic Orders. Today, we have invited three esteemed guest speakers, Professor Rama Baru, Sri Keshav Desiraju, and Dr. Nachiket Mor for a panel discussion on reimagining public health, rebuilding India's healthcare system. The session will be moderated by Dr. Amir Ullah Khan. Dr. Khan is a health economist and professor at MCRHRDI of the Government of Telangana. He is visiting faculty at the School of Public Policy and Governance, Hyderabad. He is also visiting professor at the Indian School of Business and at Nalsar University of Law, Hyderabad. He was senior advisor at the Bill and Melinda Gates Foundation, director at India Development Foundation, and executive director at Encyclopedia Britannica. Before inviting Dr. Khan to introduce the speaker, I would like to inform our speakers and participants that this session is being recorded for the purpose of our web channel. Now, I would like to invite Dr. Khan to introduce our speakers.
Thank you so much, Dr. Pandey. Thanks to Professor Asim Prakash for having invited me to convene this panel and given me the chance to get some of my favorite experts together to discuss some aspects that are new and challenging. And that's why for all the participants, you will notice that the three eminent people that we have gathered have been very carefully chosen for their enormous body of work that we are all grateful for in the health domain. Professor Rama Baru is possibly our foremost community health academics in the country. She has a number of credentials to her credit, but the reason for me really requesting her to join this panel was that there is nobody like her who understands comparative health systems, who understands unequal access to healthcare, and very importantly, who understands the Chinese health industry so very well. That is, apart from a number of credentials to her credit, her enormous amount of academic work, her respect in the health community, these are the three major reasons why Professor Rama Baru was requested, and she very, very kindly agreed to be part of this panel. Thanks, Professor Baru. I have known you for so long, read you, been your student in indirect ways. Great to have you on this panel. We then have Mr. Keshav Desiraju. Keshav sir, as we call him in the service, is one of the most exemplary officers in the IAS who I don't know whether he knows this, but who is a little case study in the foundation course that we took this year and had a presentation on him and his work. I have known him personally because when he was heading the health ministry and I was at the Gates Foundation, then we worked very closely with him, found that he was a partner who really understood what healthcare meant, what the responsibilities of the state are, and how civil society can help the healthcare system. Mr. Desiraju is one of those officers who has helped build institutions while he was being in the service, and in his last position as Secretary Government of India in the Health Department, in the Health Ministry, he has some very seminal contributions. He is a thinking person, he has tremendous insights, and that is primarily the reason why the title of this panel fits him so well in terms of reimagining the healthcare systems in the country. Thank you so much, sir, for joining us in this panel, taking your time out, and when we are really looking forward to your really sharp and keen insights. Dr. Nachiket Mor, everybody really knows him, and his distinction is that people know him across sectors. He is one of our foremost bankers. He is somebody who has worked extensively in the civil society and in the public health domain. He is one of our finest academics, someone who has led a large number of studies and reforms. His latest work on health system redesign is something that some of us have read very keenly. I have known Dr. Mor for several years now and have been a great fan of all his initiatives that he has made in every possible area that he has worked in, which includes financing of healthcare, which is going to be a serious issue as we go forward. So that's the I could go on and on about this panel. Could take half an hour of just introducing the panel members, but I'll stop there. And what I will do is, to begin with, I'm going to put my first question to Professor Rama Baru. Professor Baru, the big question is, and this is, as I warned you a little bit, it has to do with your knowledge of China. And my question to begin with is that what's your big answer on China's role? Did China handle this well? Did China make a mistake? Is President Trump justified in being upset with China? And what are the lessons that we learn from how China handled this issue? This is a broad question. You may answer it as you want. You have to unmute yourself, Professor Baru. You are muted.
Sorry.
Yeah.
I just want to start by saying I think the very nature of this particular epidemic, which began in China and then became pandemic, the real issue is that we really did not know or anticipate or had any earlier experience with the coronavirus. Of course, SARS epidemic, the SARS virus is also belongs to the same family, but we didn't quite know the behavior of this particular pathogen. I think the Chinese, the early cases were reported. I mean, the symptoms of this particular problem was reported by end November and even December. And I think there the story is really about the response of the Chinese healthcare system in time. And this also goes back to the fact that their surveillance and their response to a rather unusual fever, which seemed to then lead to mortality, was they weren't as quick in their response. But once it became a problem in Wuhan, you did find an extraordinarily swift response from the government. So in a sense, there were many issues here of a province reporting to the center, taking cognizance from individual practitioners who were alerting the system as early as December. So you have a lot of public health questions of surveillance, of being able to respond, to be able to recognize. But one thing you must grant to the Chinese is that once they did recognize it and started seeing the escalation of cases, their response was extremely swift and rapid. And most of those measures were non-medical measures. The point really is this whole idea of the lockdown, which we are now seeing globally, is what we have learned from the Chinese. And also the ability to immediately do the RNA sequencing, to be able to identify it. You see, one of the things I want to just step back because it kind of connects to what you asked about Trump. See, in the globalized world of science, the extent of international collaborations has been very, very high. And if you look at even the history of the Sino-US relationship in scientific research, 20 years back, there has been this collaboration, and that collaboration has been a two-way process in the sense that the Chinese have sent scientists of different levels to get trained in the US. NIH has given grants to the US. there has been a lot of collaborative work. And if any breakthrough in science is now no longer a national effort in that sense, you have collaboration of people from labs across the world working on similar things, coming together through partnerships and through, projects that have been funded through collaborative means. So I would say Trump saying that, oh, this was a problem that the Chinese hid, I think is an unfair comment, partly because there has been a lot of collaboration since to deal with this issue of identifying the virus, to understand the behavior of the virus, to even develop vaccines. So, this notion that somehow a lab in the US or the lab in China were somehow disconnected is really a fallacy. And I think we need to understand the global politics of science funding, science collaboration, and I think we should celebrate science collaboration. So you do have, you've had a history now in the post-globalized world of knowledge networks, and knowledge networks that in a sense transcend national boundaries. So, I mean, I would respond by saying that yes, the Chinese were taken by surprise. I don't think that they acted as quickly as they should have. But having said that, it is also that the nature of this disease, the understanding, the scientific understanding of it was also very nascent. So it's as if we are learning as the pandemic progresses. And the Chinese clearly led the path for us in that sense of how you deal with an epidemic. And many of the practices that we see in most of our countries is something that we have learned from the Chinese examples.
Wonderful, Professor Baru. That gives me the perfect segue to move to Mr. Desiraju. So, Rama Baru pointed out that, and the major point that I take from what she said was that it is the Chinese who showed us the way, and what we are all doing in some sense follows from the medical and the non-medical steps that the Chinese government and the Chinese province of Wuhan took. Your big view on what we did. Did we do the right things? Were we late in getting onto a lockdown? Did we panic early? Do you think that your erstwhile Ministry of Health and Family Welfare, where did it do right and where did it make mistakes? A broad overview of what you thought was the Indian response. May I invite you to unmute your microphone and answer this question? So you have to unmute. You are on mute.
Is that better? Is that better? Hello.
Yes, sir. I can hear you.
Yes, yes.
We can hear you, sir.
We can hear you. Yeah, please. You have muted yourself again.
Is that better?
Yes, we can hear you.
Can you hear me?
Yes.
Can you?
Yes, yes, we can, sir. We can. Yes.
Yeah, I'm asking about whether
We are missing your audio. I think
Sir got disconnected.
I think we've lost Mr. Desiraju. All right. While we get him back, may I move to Dr. Mor? Dr. Nachiket Mor again. The point that Professor Baru made about internationalization of knowledge and science and research. You have been someone who's understood this, seen this as at close quarters, worked across the world. What is your view, Dr. Mor? The big question that everybody is asking, and maybe unfairly, but let me put that question to you. The multiple choice question is, how soon are we going to get the vaccine? But that, that I'm sure you will possibly attempt to give us a date. But broadly, the issue is that how important do you think it is for us to have this global collaboration to develop this vaccine, and how do you see it going? Do you think it is going in the right direction? Are we getting caught in all sorts of conflicts? And what should be India's role? That is my broad question to you.
So there are two levels at which I thought I might just share my initial remarks. One is, on the vaccine question that you raised with me. The other is on our response overall until the vaccine shows up at our doorstep. On the vaccine, my understanding is that the vaccine industry has developed a tradition of global collaboration for quite a while now. India is a large manufacturing hub of vaccines, and I'm actually quite confident that India will play an important role, both because we are no longer just manufacturers. There are vaccines that have been developed by our companies and our scientists earlier, and we are as much now a development partner as well as a manufacturing partner. So my belief is that there is a well-developed culture of collaboration between countries on vaccines. And I certainly hope, and Dr. Rama Baru might have a better sense of this, but that borders remain open for this kind of collaboration, that there isn't a sense of, I made the vaccine, so I will keep the vaccine. I think that would be an enormous error and set us back quite a bit, because this is indeed something that will need people to work on a variety of fronts to make the progress happen. One particular aspect of this disease is its unique mortality profile. While it impacts everybody, the mortality is far more concentrated on the senior age group. And developing a safe and efficacious vaccine that works with that age group is a somewhat more challenging prospect than a vaccine that works in a young child. So clearly it will need a lot of data to be put together. And I think that's already happening. The technology, communication, knowledge, information sometimes is flowing too rapidly. The preprint stock is growing far more quickly than the referee journal stock. There's a lot of good work going on there. I mean, somebody like me that I'm part of a group that is investing in new ways to make masks, N95 masks. The access that we have to deep science going on in remote labs around the world is just unparalleled. I've never seen something like this happen. So I see no reason why in the vaccine world it should not happen. There is one asymmetry, though, which in some ways benefits us as Indians relative to perhaps the rest of the world, is the manufacturing capacity is very heavily concentrated in India. Somewhere near 60% of vaccines that are supplied by Gavi globally are manufactured in India. And that I think does give us somewhat of an edge, though my sense is we are governed by international treaties, international guidelines. So I certainly am of the view that we should continue to regard ourselves as interested in the well-being and the safety of the world and the population of the world, and not start to take an excessively nationalistic, narrow view once the manufacturing process starts. But there's the other aspect. What are we supposed to do about our response to the disease? As Dr. Baru pointed out, that Chinese implemented a certain pathway, and then the rest of the world, in a sense, has learned from them and adapted it in some ways to try and see what they can do. My own sense is, given our reality, and if there is time, we can talk about it some more. That's perhaps where we have gone wrong, and that we have not fully acknowledged the unique situation of our country, the unique realities of our country, the traditions of how we operate, and in some ways, European ideas, ideas from somewhat more advanced economies have found stronger purchase in our consciousness and how we think about it. And we've ignored, for example, there is a passionate article, and New England Journal of Medicine is not known for writing passionate articles, but there is a passionate article in NEJM from doctors in Lombardy, in Italy, where they beg the world to learn from them and not build a hospital ventilator centralized isolation strategy as the core strategy for responding to this, and not to work under the presumption that the disease burden will remain at low levels. All of these were mistakes that Lombardy made. Now, my sense is it may still turn out that our assumption of a low disease burden is the right one in the long run. We don't know what the numbers will look like, but there doesn't seem to be any presumptive reason why we should make that anything unique about the virus is any mutation that we are seeing. And I do believe that countries like ours, given our backgrounds, needed to have and still need to have thought through an entirely different approach towards addressing this issue. In the initial weeks of the crisis, I can understand there is a sense of uncertainty, the sense of panic, so you're doing what everybody else is doing. But now that we are several weeks and months into the process, I think there is a time for reflection. So while on the vaccine front, I'm all for let's do the best that is possible in the world and not worry about, whether it's Indian or non-Indian or Chinese or Japanese. I think in terms of the on-ground strategy, we may have to spend time thinking about what is our unique approach. I will stop here. Thank you.
Thanks so much, Dr. Mor. That's such a refreshing and a very insightful way of putting it. That and connecting the two together. That on the knowledge sharing, on the vaccine development front, while we need an international view and an international collaboration, what we might have profited more from doing was to take an indigenous view at addressing our own ways of handling this issue. Brilliant, and I'm thankful to you for that. Now that Mr. Desiraju is back, sir, if you can unmute yourself and we can hear from you. Following, as you must have heard, Dr. Mor talked about the Indian experience and the Indian reaction or the Indian handling of the issue. What is your view there? So Desiraju's bandwidth issues also are showing up.
I thought it was working fine.
All right. Yeah, it was working fine during the introduction. Yeah. All right. Now he's dropped off again. But all right. So let me get back and go to Professor Baru again. Professor Baru, when I was doing this preparation, one question that kept coming back to me, and it's a question that everybody is asking, and I thought that it's the right question to ask to a senior academic who understands these issues very well, and that is this whole testing issue. Why is this constant criticism that we are not testing enough, that we should be testing more, there should be new ways of testing? How do we sample our test better? Do we do group testing? What is your view? I mean, is a major problem the fact that we are either unable to or unwilling to test? Unmute yourself, please. Unmute, yeah.
I think this kind of, I'd like to go back to where Nachiket Mor alluded to, which is that what was us, when you say, were we prepared to respond to this pandemic? I think we were late in responding. And I think testing is one part of that whole story. And if you look at the preparedness as far as testing is concerned, first, there were only government hospitals and very few of them that were authorized for testing. Then they roped in some private testing labs. And if you look at the, those clearly become extremely urban centered and they're very few in number. The numbers to be tested are very large. But then I think the issue really was within India. I mean, while the Chinese model became kind of a global way in which it was spanned out and then adapted, you had Kerala within India, which also had a model of how to deal with the epidemic. And their response was much, much earlier than the central government. And I think the question that we need to ask is, they did employ testing, but you can use testing prudently. You can decide how you want to use the limited facilities you have for testing. Then we realize we don't have the rapid testing kits. So then we are, importing it from China, and it comes very late in the game. And then when it comes, you realize that it is not, it is producing too many false positives, and, the whole question around what was the quality of the diagnostic kits that were being employed. So I think then everybody said, why don't we go the South Korean way? I think for that, you would need resources of an order, which I don't think we have. And since health is a state subject, and to this day, I don't see the central government really, doing any major fiscal devolution to states. How are states supposed to spend money to procure testing, to test the entire population? You cannot do a door-to-door testing. Then you employ other means, that you look at clusters, you test people who are coming from outside, you follow up with the contact. It's a very labor-intensive public health approach. And you could not have done anything better than what Kerala did in the Indian context. So I think it would be all right to say that we were not prepared with the, the quantum as well as the quality of diagnostic kits, which went beyond a hospital model of testing for coronavirus. So I think there was a lag in many of these, and it really surprises me, because after all, we flew students out of Wuhan end of January, early Feb. What were we doing till March 20th? Kerala had already acted. Kerala was in an active surveillance mode. They were preparing for hospital beds. They were doing a whole lot of things. But what was the rest of this country doing? And I think there is a real question there. I think I would love to find out, what was it? Did we just think that it wouldn't hit us? That we would manage it somehow? I'm not so sure. I mean, I don't have the answers for that.
Thank you, Dr. Baru. Dr. Mor, on the testing issue, did we make a mistake in not getting the private sector in? Should we have guaranteed free testing for everybody wherever they went and got tested? Should the state have come and capped rate for testing? And the same question for the treatment that is coming up now, that in the treatment of those who are positive, who should pay? Can people go to the private sector? And then that entire issue is coming up again, that the private sector is profiteering, it is charging people very high, the insurance companies are in trouble, they don't know how to handle this. What's your views, and what should be the view on private sector in testing and in treatment?
My sense, building off what Dr. Baru said, I feel, we don't know how the pandemic is going to pan out. So there is anybody's guess as one moves forward. Is the number, if you see the Imperial College COVID team, modeling team, they have gone so far as to project a number of 65% of the population infected in India. And that's the do nothing case. And the best case is not that far away from that number. Objective reality may prove to be entirely different. We may find on the ground numbers that are, because of the action governments have taken, of the action citizens have taken or not taken, we may see numbers that are quite different. The question, therefore, for a policymaker, for somebody sitting here today who doesn't know how this is going to pan out, and what should be the reaction. Now, if we were the first nation, as Dr. Baru pointed out, where something like this happened, I can still understand taking a view that one should not be overreactive, because otherwise, every 2 days there is something new that is going on in the world. You are constantly crying wolf, and after a while the world is exhausted by this, because out of every 200 things that you cried wolf about, maybe one thing was the big issue. So I can see there is some debate now. WHO, make the decision too early or too late. Should they have done something else? Now, we can always be wise by hindsight. We can always say, this was what should have happened once we have full information. But I see no real reason why a late starter country, us or countries in Africa, should take anything but the most extreme view about how the disease is going to pan out. Because there's no real reason to believe that we will not be another New York, or that Bombay will not be another New York. We can hope, and I certainly am amongst those that would like to hope that. But in terms of preparation, I don't think we can now make the assumption that this will pass us by. We have too much information from around the world that tells us that that's not going to happen. So I'm entirely with Dr. Baru that Kerala, and it's not just Kerala. Like if you look at, I'm told the first case in South Korea and in the US were at the same time. Right? One country is crossing thousands of deaths. One country has barely crossed 500 deaths. It's a matter of what action was taken. Both are rich, advanced countries, have enormous potential, enormous capacity. So clearly action should have, under the uncertainty of what's going to happen, should assume even today, because it's not too late. India is still not at the late stage of the crisis. We still have time. Now, your detailed question around testing, not testing, the objective reality is the world has not behaved well as far as testing kits are concerned. There's been a mad rush and competition between governments. I understand in the US, states have started to compete with each other on testing kits. Quality, yes, there's always a concern about quality, but at these times, people are scrambling to get hold of what they can. And at a household level, people are buying groceries like there's going to be supermarkets are going to run out. Similarly, testing kits are going in that way. So in some ways, there is a global limitation on this. But so in fact, I would ask, my own understanding is that there was a desire to ramp up testing as soon as possible, as much as possible. There was some concern or some delay perhaps on the part of, how to get the private sector involved, not involved. Partly it was a pricing question, partly it's a quality question. You don't want to bring in a lot of players that are going to produce numbers that are going to be inconsistent. And private sector, while has the best of quality, unfortunately, is also a record of it not having the right level of quality. I would be less interested in now looking back to say should we have acted a week or two earlier, or should we, have done something more? As on today, I think we are firing on all cylinders. We are operative in as many places as we can be. I still do have a concern that our presumption that there is no community transmission, our presumption that the cases are coming only from travel histories and from contact. I feel now the caseload is getting to a point where this is becoming increasingly less and less tenable. Now, if indeed there is community transmission, then the entire testing strategy has to change. It has to go back to a more traditional testing approach in which you are doing more random sampling. You may risk weight it because, when people present these two as contrasts, that either I can do random sampling or I can do risk-based sampling. Well, no, actually you can blend the two. You can oversample high-risk cases and undersample low-risk cases. But in some ways you start to get a view, and particularly as we are debating opening up. Because we can't take the view of opening up on the basis of, I tested people who were sick and I found that they were sick, right? Well, that's good. But now that doesn't tell me, was the disease there or is that just where I shone the light? And I opened in places where I should not have opened. Dr. Srinath Reddy mentioned yesterday this concern that this, we still, I would say in other times it's not a benefit, but in today's times there is a somewhat of a benefit. We have many isolated communities that live around this large landmass of ours. Right? Now, maybe there is an opportunity for us to try and see if we can protect them for the next 1 or 2 years until we get the vaccine. But if we don't have a sense of where the true disease is, even with an error band, even with a risk band, I think we might, inadvertently be creating more intermixing than we have. And I have written about this. There is a very nice piece from Professor Subramaniam of Harvard University on this, and now IHM, Chris Murray's group, is also starting to talk about, your testing strategy. That I think we may still have to examine more, because no matter how many tests you get, relative to our population, relative to the size of the people that are infected, it's always going to be in short supply. We'll never get to the 7,000, 8,000 tests per 100,000 in a long time, even in larger locations. So we will have to strategize. We'll have to be smart about what kits we use and how we use it.
Thank you, Dr. Mor. We have Mr. Desiraju on the phone, so we won't see him. But sir, welcome back. Sorry for this inconvenience of technology, but we'd like to hear from you. We would have certainly liked to see you also, but we'd like to hear from you on what you think is is your commentary on how we reacted to this and how we took this challenge. Yes.
Can you hear me?
Very loud and clear.
Can you
please.
hear me?
Yes. Sir.
Oh, good. Fine. Yeah. Well, my apologies for being so erratic about this. I'm sorry about this. Now, listen, this whole conduct, you asked me to start with about lockdown. And while I'm quite clear that at the time lockdown was announced, it seemed like a sensible thing to do because it certainly has helped in curbing the spread of infection. However, there were many things we should have done post-lockdown, which we did not do. The first is identifying amongst our population those who were most at risk. I don't think any effort was made. We've been focusing only on geographical concentration or geographical points of concentration. We've not been thinking about who amongst the population is most at risk: the elderly, the people with comorbid conditions, the acutely diabetic, the people whose blood pressure is uncontrolled. Stuff like this, all of which we would have known if we had had a properly functioning public health system. So this is something we could have done during lockdown. There's still, of course, I hope it is being done at least now, but we didn't do it in time. The second thing we didn't do was strengthen our public facilities, district hospitals, to give a crucial example. Knowing that those would be the focal points where people with illness would arrive, knowing that the private hospital system is not pulling its weight, we did not either requisition beds in private hospitals, except a few cases in Mumbai Corporation and things, or we did not do enough to strengthen our government facilities. That again is the second thing we didn't do. And the third and perhaps most calamitous thing that we did not do was we did not recognize the migrant story. And I have a terrible suspicion that no one thought about this. No one in policy-making circles seems to have thought about the fact that if you suddenly close down workplaces, that a significant, in the big cities, a significant number of the worker population, which has no other connection with that city where they are working, automatically get put out of a job. They have no money, no food, no shelter, and will begin to want to leave. That this clearly was not thought about, and everything we've been doing in the last 7 weeks seems to be making the problem worse. So just to try and sum that up, I do believe lockdown was necessary when it was announced, but we didn't do many of the things that we ought to have done in the time that we bought for ourselves. And our position today is not so much better than it could otherwise have been. Thanks.
Wonderful, sir. Thank you so much. You know, this takes me to the last part of our discussion, and obviously the one that that most people would be waiting to hear all of you on, and that is this whole package that, you know, Professor Baru talked about, the non-medical issues, the economic. Everybody's been talking about the economy and how that is suffering, the cure being worse than the disease, all of that. So now that we have the federal government finally moving and announcing what seems to be a very large amount of money, at least, that the number of zeros are pretty impressive. But what is it that that all of you, having seen some details coming out over the 2 days, feel on this issue, on the issue of how the government is going to handle the aftermath, the migrant issue, the poor, the farmer, the economy, whether this kind of stimulus to the MSMEs, etc., to the banks, how is it going to pan out? How is it going to work out? How different could it have been? If I can start off with Dr. Mor, and then go to Mr. Desiraju, and then to Professor Baru.
I mean, I must say that, you know, the size of the overall number that has been announced by the government, even though one can do detailed discussion and say, you know, so-and-so number is double counted, so-and-so number is triple counted, I think certainly is worthy of acknowledgement. That, you know, certainly one could do more. One could argue a straightforward fiscal effort instead of through multiple channels, via guarantees, via this, via that. One could take a view, is that really a contribution, or is that simply a part of a general effort? So I certainly think that is a positive. The challenge that I think has emerged quite quickly is the intent, the decision to the delivery. There has been a large gap. I understand there is research published by Dwara Research that came up in the library that somewhere near 39% of transactions are failing at the front point. That means I've got a cash transfer. I cannot draw the cash. I also have a channel member, a post office payment bank, a Fino payment bank, an Airtel payment bank, a business correspondent. Somebody is there, but the transaction is not going through. And Some of the problems are around the Aadhaar authentication, but I understand a significant portion of the problems are because banking systems are not processing those transactions at the speed that they should. Now, I don't study this subject in detail, but I would say this is fixable. We can't discover the vaccine in 2 weeks. That's not possible. But this problem, you know, there are only actually 3-4 banks and 1 or 2 clearing houses that need to sit together with the Reserve Bank of India and fix this. Because we have actually built out over the last 4-5 years, 10 years, an infrastructure that is actually quite strong. The second concern I would have is that this is a systemic crisis. This is not a crisis that is of anybody's making. It deserves of a systemic response, which means we have to be careful that we don't use this as another mechanism to start picking favorites and start saying, I'll support this industry and not support that industry and do something else. This is not the right time to do that. A non-discretionary, mechanical, approach is what is called for here, so that the economy, all of the years of work around comparative advantage, etc., doesn't get undone because somebody who was actually well positioned and is well positioned to survive and do well even in the future is unable to do so because your current approach, really pushed in one direction versus another direction. And again, this is not my expertise, but from what I can see, there's a lot of detailing and nitpicking that, at least at a first glance, I would have eschewed. So I'll stop here.
Thanks, Dr. Mor. Mr. Desiraju, your response?
Yeah. Now I think there's a one very big constituency that India will need to look at as soon as things begin to, I mean, I don't like using the word normalize, but when lockdown is lifted a little more, and this is the huge number of people who have fallen off the health map, non-COVID patients. So there's been a lot written about patients who are dependent critically on daily medication, regulated, systematic way, who have probably not had access to medication this time. There are diabetics, hypertensives, cancer survivors who need regular medication. Vikram Patel has been writing and talking about the spurt in attempts to suicide and various other reflections of mental illness at this time. Now, this is going to live with us for a very, very long time. Another very important area is universal immunization. India has something like 70,000 babies born every day. I think the 26 million per year comes to something like that. Now, I'm told that in several states, universal immunization collapsed through lockdown. It is only now picking up with ASHAs and ANMs coming back to their work. Now, we will know whether this is really happening if there is a measles or a diphtheria outbreak in the coming months. So the crucial thing that needs to be done post-lockdown, as it were, is an identification of those people whose health needs have been badly affected during lockdown. So nothing to do with COVID, but these are the people who have fallen off the map, who need to be identified and attended to without any loss of time. I think that no one is talking about this now, but this is going to need a lot of attention. The other thing, which again I hope very much that the moment things seem to be normalizing, that it doesn't just become business as usual. We have to see large budgetary increases, both from the state governments and from the center. Without that, without strengthening of the public healthcare system, we have seen what many, many decades of that can do, as in Kerala. I don't think we need any more lessons. So that, I hope, will be something that the government gives its full attention to post-lockdown. Thanks.
Thanks, Dr. Desiraju. Over to you, Professor Baru. Your comments.
I just wanted to go back to what Nachiket Mor said earlier about, when you have these large sums being announced as economic packages, that you don't get into creating favoritism. And I think that there is a danger of that. And I also don't see the role of the state being adequately represented or respected in the center state discourses. While the Prime Minister has had several rounds of discussions with chief ministers, are the needs of states being really, dialogued with the center? I don't see this dialogue happening very significantly. And I think in any fiscal devolution, if you want to talk about strengthening public health systems at the state level, if you read reports from various states, they're already in the red, which is why, I remember another webinar where Sujata Rao made this point. Why did liquor shops get opened by state governments? Because they were wanting to augment their revenues. So, what its fallout was terrible, whatever happened. But the point really seeing is that many of the states do not have the kind of financial resources to keep up with the demands of COVID and routine care. So I think the point that Keshav made was very, very important about what is happening to routine care. What is happening to the needs of people who have comorbidities? What if you need an elective surgery tomorrow and if you want to go for care, many of your hospitals are not taking on COVID patients. So what is going to happen to routine care at the secondary and tertiary level, and certainly all your national health programs? There are disruptions in the working of national health programs because you are now shifting your attention to COVID, and you only have so much of human resource capacity to manage it. What I'm really concerned about, and this is the other issue that Keshav raised, is that once lockdown is lifted, are we going to go back to business as usual? And I can tell you what will happen. The task shifting will shift to the ASHAs. ASHAs will do everything. They will have to do your programs. They will have to do your COVID programs, and they're all not, paid part of. They're not a cadre in the health service system, so they can be, pushed around and told to, do the tasks that are required, and they're already overburdened. So, what Nachiket Mor said and what Keshav has also been saying is, these are all systemic issues. You need systemic responses. It cannot be that you can have, add on piecemeal, new ideas just thrown. You cannot do that. And ultimately, the states are going to carry this burden. So even if you have a fiscal package, and if you don't devolve to the states according to their need and according to their plan, I'm afraid that, all the hype that you do with the numbers and the zeros, in my view, would become meaningless.
Thank you so much, Professor Baru. Thanks to all of you for having addressed these broad issues with such clarity and with such insight, just as we had expected. I'm now going to throw this open. There are a few questions that I already got, and I will ask these questions on behalf of the participants. The first question to Mr. Desiraju is a very interesting one that Shruti has asked, and she wants to know, is there any mechanism that allows us, at least now, to deal with future pandemic-like situations? This one caught us by surprise, as Dr. Mor said it shouldn't have, but it did. And is there anything that we have or will do to ensure that we are not again caught unawares by a pandemic-like situation in the future? Mr. Desiraju, can you hear me?
Disease Surveillance Program, IDSP.
Yeah.
Now, this is the job of these institutions and structures. The IDSP's job, it is to track the spread of disease, and we have seen reports which said that even as in up to early February, IDSP had reported 3 cases of 3 COVID patients. Very mysteriously, the IDSP has stopped reporting after early February. So are we in a position to plan for future pandemics? Certainly we are, and we don't need to create new institutions. We have them. We just need to allow existing institutions to work, and they need to be given the support and the funding that they require. I think that's what needs to be done.
Thank you so much. Dr. Baru, there is this question on the testing that one is that we are not doing enough. We've discussed that. But even the tests that we are doing, are we under-reporting? You know, there is this lurking feeling that the numbers don't sound right. For example, the Delhi case that was reported yesterday, that if you count the number of dead, then that's 400. But if you ask the government how many have died of COVID, then it's 109. So it's like 3 times more. What is happening? Is there a disconnect, or is it just some little data issue that needs to be cleaned up?
I think quite a few people have written about this question of underreporting. And I also, more recently, there have been reports about how there has been an effort to suppress the number of, suppress the reporting of cases and even deaths. Now, I think one, that the state level reporting also has to do with the robustness of the surveillance systems and the public health system. But that having been said, this whole question of the cause of death, there was an excellent piece written by an NHS person a couple of weeks ago. Sorry, it was in the Spectator. I don't remember the name now.
Yeah.
Who basically talked about what is the, how do you decide a death is due to COVID? You have to test the patient to say that they've died of COVID, or they may have symptoms. You can even register that same death as respiratory distress or a cardiac arrest. So I think the whole point is that you need to certify that death as COVID. Now, we also know that a lot of people have stopped going to hospitals even when they are feeling very sick, because they feel that if they go there, that they may not get the required treatment, or that they may contract COVID and then succumb to it later on. So, I mean, there are a whole lot of issues here about the actual numbers. Do we really have a grip on the numbers? And I think today, even within the ICMR, there was an interview given by one of the senior officials of ICMR a couple of weeks ago, where he said that, that there are discrepancies in the data.
Yeah.
So the point really is that I do believe that there may be underreporting from certain parts. There may be better reporting from other parts of the country. And there may be an effort to also underreport. Because there is this great fear of how do we deal with this problem. And that connects back to, I think, what Mr. Moore said earlier, which is that I do believe community transmission has happened. And Professor Mulial from CMC Vellore an excellent piece almost a month ago, where he did say that community transmission has probably occurred. It's best for us to accept that community transmission has happened and then deal with it, rather than say that no community transmission has happened. And then, of course, we move to this whole theory, which is now being advocated, which is that we'll all live with herd immunity. These are things that epidemiologists have said much earlier in this whole pandemic. So, I mean, that's about it.
Thank you. Dr. Moore, Amita has a very interesting question, and that goes to the original announcement that we had heard from the Prime Minister himself, that there will be a task force that will be set up. The question is that this is a state-led response that we are seeing. Is our bureaucracy equipped enough to lead this? Does it need expert advice from others? And the central role seems to be played out by the police. So where do you see it, and what kind of a mechanism would you have wanted to see to tackle this? Or is the mechanism that is being used, which is bureaucracy, police, the kind of thing that we need to look at?
This is something I alluded to when I made my opening remarks about how our approach on the ground has been quite different and could still be, and that of many other developing countries could be different from what elsewhere has been done. A hospital ventilator strategy, which and a centralized strategy in which you're trying to move patients into central isolation wards. The Italian experience has been that you can quickly get overrun, even in a highly equipped space, unless you make the heroic assumption that our infection rates would remain in the neighborhood of 10 to 20 per 100,000. Italy started to face this problem at 300 per 100,000. I shudder to think if the numbers turn out to be 30% and 40%, then clearly these systems are going to get old. We also know one more thing, that those people that end up on the ventilator, I'm not saying therefore we should not invest in ventilators, but we should be conscious that mortality on ventilators is very high, as high as 80%. So if I take every 100 people that are infected and we make the assumption that about 80 people will experience mild symptoms and be fine, 20 people will need attention. Of the 20, about 15, 75 to 80% of that 20 actually does quite well on oxygen. Making oxygen available in non-ICU, non-hospital settings in a wide way, to me, still looks like an interesting approach, a useful approach to include as a complement to the ventilator. What I like about that approach is, in a way, echoing what Desiraju also said, that if you build this at district settings or block settings, whether in the government or the private sector, and even if we are all overreacting, and the district turns out to have very modest profile, you've left behind a much stronger primary care sector. Yeah. Because oxygen capability is useful for a number of issues, not just for COVID-19. So clearly there is an opportunity there to have done something. But the other thing that, I would say there's still an opportunity for us to think about is to involve the community a lot more than we have chosen to do. We have issued instructions and diktats to people to move, to stop, to go. And maybe in the initial stages, that might still be called for because nobody is clear what to do. The reality, though, is that if we are planning to open up, if we are planning to, settle down into an environment which is, going to be this of a COVID environment for an extended period, then we have to take the community into confidence, work with them much more closely. Desiraju said earlier that we are communicating a message, social distancing, masks, but we have to communicate, in my view, a sharper message to say the infection is here to stay. It will stay here for a while. Most people are not at risk, so do not panic. Do not prevent your migrant brothers from coming back. Most of you are going to be sick. There is a narrow profile of senior citizens that are going to be at severe risk. Make sure you protect them using these measures and these practices. And I would say these are opportunities that we have, uniquely as a poor developing country, that perhaps other developed countries have not had to worry about. But these are our strengths. I feel today we have asked these community structures to be on standby. We have asked them to really not get involved as much, except as referral mechanisms. That is something we may want to re-examine if we want to put together a durable and sustained response.
Thank you, Mr. Desiraju. This question that Vikash asks
Yes.
And this is an interesting question. This is on your view on what is happening in Bengal. You know, we don't seem to be very clear. These two, you know, one state in the east, Bengal, and one in the west, Gujarat. Something seems to be happening in these two states, and Gujarat just jumped up to rank number 2 without, you know, any notice. And Bengal, we don't know what's going on. What's your view? What is happening in these two states?
Well, I don't have first-hand information, but my sense of Gujarat is that there were there was not so, it was not a very tight implementation of lockdown to start with. And I think they lost some time on that. And in Bengal, I suspect it's possible that they are testing more than others. But I really, I mean, I don't have a more nuanced answer to this question. I'm sorry, no.
No. That's fair enough. Mr. Desiraju, while you are there, you know, this other question that Himantika asks, which is that, you know, these frontline workers,
Yes.
the ashas that Professor Baru talked about, now they are going to have a disproportionate exposure to the disease. So what
Yes.
kind of occupational safety measures do we have, should we have, or are we just throwing them to the water?
You know, that's a good question, but it's part of a much larger question. At the front line, we have 3 categories of women employees who do the bulk of public health work in India. There are the auxiliary nurse midwives, the ANMs, who are government servants. There are Anganwadi workers who run the Anganwadis under the ICDS program, who get fixed honorarium every month. The amount of the honorarium varies between states. They are not government servants. And there are the ashas who are incentive based, who get a small sum of money for every task which is performed. And depending on how many tasks they perform, they make different amounts of money. Now, as Dr. Baru just said, the standard reaction in government whenever a problem comes up is let the ASHA do it. And the reason for this is because you have the greatest control over the ASHA. Since she's really not even a government employee, she can be sacked at a moment's notice. And that is the way in which people get work out of her. I mean, these are truths that are not widely spoken, but this actually is what is going on the ground. Now, ANMs, because they are government employees, probably have some sort of not medical cover maybe, but probably better access to medical facilities within the district. Ashas and Anganwadi workers have no real medical cover, and this it actually is a big issue that post-lockdown government of India will have to take a call on. That if we recognize that we need to build up public health cadres using these women who work so magnificently actually, how do we bring them into the system? How do we ensure that they continue to work well even after they become regularized, pensionable government servants? What is the kind of training they need? And of course, you know, what is the kind of protection they need and everything else? This is a very important question. It will involve a fairly large payout of money, but in my view, it is something that it's worth thinking about and doing. Thank you.
Professor Baru, there is a question that Lakshmi Lingam has, which is that do we have any sense of the demographics, the socio-economic profile of those who are getting infected? You know, like, is it like the US where disproportionate number is the poor black community? Is it, we know that it is affecting the 50 plus more, but apart from that, do we have any more breakups on what kind of people are more vulnerable?
Actually, we don't get very much data on the socioeconomic profile. We do, of course, get, you know, the first wave of deaths that were reported, they were people who were in the 60 plus bracket and who already had comorbidities. But apart from that, we really don't have robust data on who are the people who have died from COVID. And I think it's something that one would need to work on a bit more. Provided when they register the deaths, we get additional socio-demographic information. But having said that, what seems to come out very starkly in the American context is that it is the African American young people with comorbidities have a disproportionate number of deaths from inner cities of the US. And therefore, you know, they are in a sense the dispensable also. So while the panic and fear has moved the middle class into a lockdown of their own, the othering of populations, and in the Indian context, we saw that in the case of Nizamuddin. So the moment you had a particular situation that arose, which was due to administrative failure, you immediately have this othering. So it is because of the technique and their movement that cases went up in India. I mean, so, you know, you do have these kinds of fault lines emerging, these fault lines that existed, this divisiveness that existed just has got exemplified through this COVID experience. And class has come up very, very strongly. So the assertion of who's to be protected and who's left unprotected has also come out very clearly in the way in which this, the aftermath of this lockdown has.
Thank you. Dr. Mor, here's a slightly tough one for you. And really, I don't know why I'm putting it to you except for the fact that you know Bombay better than all of us. But what's about Dharavi? I mean, you know, how do you tackle a seemingly impossible situation like the slums of Dharavi? Oh, you will have to unmute. Yeah.
There are multiple issues going on in any crowded space, not just Dharavi. Clearly, transmission, when people are living in close proximity of any infection, is going to be hard. Not just coronavirus we have an issue with, we have an issue with TB. If I look at Dharavi incidence rates, mortality rates, they're double that of the rest of Bombay. Because population density is very high. Question is, what is our response? There's a very nice paper from the London School of Hygiene and Tropical Medicine in which the researchers go into what does one do in a crowded space. Now, one thing to note about this virus, which is different from other viruses, it's not vector-borne, it's not airborne. Isolation is much easier than for these other diseases. Because I don't have to control a vector. I don't have to control the flow of air. I don't need negative pressure necessarily. Unless there is aerosolization, then treatment is going on. But in a routine case. So what they recommend, which I thought was is, and again, that's where the community involvement becomes quite important, is that what if 5-6 families got together and said that one of the colis, one of the rooms is an isolation room. And that the other members of the family will move to the other room. That's effective isolation. You know, because all you need is a physical separation. You don't even need a lot of distance. So long as there is a wall or there is a partition, that can prevent it. Really, we have to think about that. Also, you know, we are using Dharavi as a broad phrase. The reality is, it's a large area, very differentiated. And this is where the testing strategy that I spoke about earlier, I think would be very important. You have to isolate areas that are non-infected or infected, assuming community transmission. At least in Dharavi, we have to assume that there is actually, community transmission. And then the question is, what about treatment options? Now, today, the numbers are still manageable, but the stories that you are hearing, particularly what we are watching about people getting overwhelmed, I would argue to you, setting up oxygen capability, either mobile or right inside the slums. Because one benefit of being in Dharavi is that you are in Bombay, which means power supply is not an issue. Oxygen cylinders are available. Right? You have the benefit of intensivists that can supervise a very large number of facilities. You can train nurses fairly quickly. So this is not a remote rural, part of the country. A rapid response can be mounted locally because not everybody needs critical care of the type that, and the beauty, there is a concern. I'm not a doctor, but I understand that a patient can decompensate rapidly on an oxygen situation. In a remote rural area, this is a bigger problem because you want to move the patient to a bigger facility. Not in Bombay. In Bombay, you can wait because you do have half an hour, 1 hour. That's enough time to move somebody to a reasonably good facility if they start to decompensate. But actually, most people will not decompensate. Now, 80% of these people will recover on oxygen and go back to work. So I'm not an expert on Dharavi. I'm not a medical doctor. But from whatever I can see, there are options in front of us that can be taken if we start to really work with the community.
Wonderful. Just the other question also to you is that, once the vaccine, and this is again Lakshmi's good, really nice question, that once the vaccine comes up, how equitable will be its distribution? Or are we going to see some sort of inequality and an unequal access to that, like we did in the SARS case?
See, this is going to have to be a mass vaccination campaign. This is not going to be a campaign of selective vaccination. India has a good record actually of vaccination. If you look at deworming, for example, this is an interesting example of how we do deworming. Hundreds of millions of children are dewormed in a relatively equitable manner. Now, there could be errors, there could be pockets. Unless the vaccine is at a price that somehow needs to be rationalized, I would submit to you that there is a real opportunity. I would say I would not worry about that as much. And India has very low cost manufacturing. The science of the vaccine is going to be hard. But once we know how to make it, mass producing it is something that we are good at. While certainly I have a bigger concern about access to treatment, access to facilities, much less so about access to vaccines.
Mr. Desiraju, here is this, in some sense, the last question that I will take from here. But do you think that the response that we have seen has been lacking in terms of not taking expert assistance from a wider range of people? It has been purely led by doctors and by policemen. What would you think would be the right way out? Have you unmuted yourself?
I don't think.
Yeah.
No.
Yeah.
Can you hear me now?
Yes.
Can you hear me now?
Yeah.
Hello.
Yes, please. Yeah.
Yeah. I was saying, no, obviously doctors and public health people need to lead the response. I don't think India can be faulted on that. I think some issues like the migrants issue, if they had taken state governments more into confidence, and this point about community participation, Nachiket was talking about it, if more people were made to feel involved, I'm sure we would have responded better. Again, I don't see that, there has been no interaction with civil society as such. And at a time of a pandemic, there clearly is a case for this. It's not necessary that government of India does everything. State governments can do this. But we have not seen signs of that happening. Everything has been pictured and put forward as government response. And I think that is unfortunate.
This follow-up question again, because you have worked and you are working very closely on this issue. What do you think is going to be the impact on mental health? There is some people have talked about it, but I don't think enough. What's your view, and what do we do there?
I think that this can take many forms. There already has been writing about increased number of cases of attempts at suicide. People who work in this area have been reporting this. It is also possible that the terrible conditions, for instance, under which the people whom we're just calling migrants are living, but a lot of people who have been thrown out of work are probably been thrown out of work, not enough money, not enough to eat. This is ripe ground for various kinds of depression to set in. It's quite possible that this is happening. And post-lockdown, as I was saying earlier, we need to track down people who have possibly had these sort of mental health consequences of what they've experienced during lockdown. Can I just take this to one other very? It's also necessary. There has been a spike both in domestic violence and unwanted pregnancy. This is really something that people need to take note of. People are writing about this, reports are coming out. The existing family planning services in the districts have probably been suspended. Many women have been deprived their access to whatever method they were using. These are difficult areas that need a lot of work. Thank you.
Thank you. May I now invite Pepin Susai? I see your hand raised. Can you briefly ask your question or your comment?
Yeah. Thank you, Professor Asif, for inviting me, and also I would like to say hello to my classmate, Professor Rama Baru. I hope Rama is able to hear me.
Wow.
Yeah, okay. As a student of public health, I have, many issues have been already answered by the esteemed panel members. But one thing I find missing is the whole idea of human resource planning. We all know that how inadequate our manpower is when it comes to public health systems, right? Now, when there is an increased burden on services, and we are still struggling to manage with existing manpower. Even in the latest allocation of 20 lakh crore, not a single word is mentioned about how are we going to address the human resources in health. I think that is one question I wanted to ask, because
very good. That's an important one.
Just one second, please. As Mr. Moore also mentioned, and also I think Mr. Desiraju also mentioned, the people at the periphery, the private, the primary health, cadre. We cannot put as Rama also said, we cannot put the entire burden on them. We need to really look at, strengthening the human resources in our institutional setup. So that is what I wanted to ask. Thank you.
Very, very important point. May I get Uma Bharti in? Uma Bharti, who is also, no, okay. We don't have Uma Bharti anymore. Now, as we come to the end of this panel, it's been really wonderful. I just had 3 very quick questions, and I'm asking all 3 of you. It's some kind of a fastest finger first kind of question. So you just answer in one word or in one phrase. And Professor Baru, you go first. So when do you see the vaccine coming? And just give a rough timeline. Unmute, please. Yeah.
Going by our past experiences of the vaccine promise, I'm not an optimist that it will happen very soon, because whatever you do, you have to go through clinical trials. You have to see the efficacy of the vaccine.
Got your answer. When do you think the lockdown is ending? There's a second question. When do you think the lockdown is ending?
Well, the lockdown will end, but then people's lives have been disrupted so badly. So you may say the lockdown will get lifted tomorrow,
Yeah.
But what does that actually mean in real terms for people's lives?
Okay, the final question to you. What do you think of the Arogya Setu app?
You know,
Just
I
one
have
phrase.
reservations about any form of this kind of surveillance. And as you know, there is a diktat for all government officials that it's mandatory. And I think there's enough written about the whole question of the, you know, what is it, will it use for surveillance, many other questions that came up in the Aadhaar case also.
All right, Mr. Desiraju, your last comment. What is it? What is the big thing that you are still missing? If you were still the Secretary, Ministry of Health and Family Welfare, one measure that you would take.
I think what is missing is substantial devolution of funds to the state governments. State governments are broke. They need money. So whether they have to strengthen hospitals, whether they have to train ashas, whether they have to, set up isolation camps, state governments need money at this point of time, and that's what they're not getting.
Dr. Mor, your view on how much of a timeline should we be prepared for? Should we be thinking of October 2020, June 2021? When are you seeing some sort of normalcy coming back?
My sense is we have to assume this virus is with us as a permanent friend. Will at one point or the other go through the population. Vaccine is anybody's guess. There is some talk that Oxford has a vaccine by September, but it will go through many trials, many efficacy issues. How safe will it be? How long will the immunity last? There are many questions ahead of us. So, from a planning perspective, when I spoke earlier about, for example, we need to worry about the vulnerable. Currently, I'm thinking about people who are beyond a certain age, 65. My message to them would be, assume you're vulnerable for an extended period. Your way, there's a lot of good evidence coming on the need to wear a mask in public. If you're above the age of 60 or 65, the need to wear a mask even at home, unless you live, because you could get infected from a young person. And to get used to doing that on a perpetual basis.
Thank you so much, Dr. Mor. I think this has been a most wonderful panel. This is my personal vote of thanks to the three of you. I owe each one of you one. You may please encash that check whenever you want to. But thanks so much for joining here, for being so very upright, so very clear, so very crisp in all that you said. Thanks to all the participants. I hope that this panel did give you what you were looking for. I am extremely enriched. It's answered several of the questions that I was worried about for quite some time. I must hand this over to Dr. Pandey and Professor Aseem Prakash with a personal note of thanks to both of them for having done this so seamlessly. So on behalf of this and the faculty and everybody, one of us who's worried about India's public health, thanks to the three stalwarts who answered all my questions and all our questions so very well. Over to you, Dr.
Thank you very much for asking us. Thank you.
Thank you, Amir, for a very lively and energized discussion.
Thanks, Dr. Mor. I think Dr. Pandey needs a minute or so for a formal vote of thanks. So, if you can stay for a couple of minutes.
So, on behalf of the School of Public Policy and Governance, Tata Institute of Social Science, I would like to thank Professor Rama Baru, Dr. Nachiket Mor, and Mr. Keshav Desiraju for engaging us such a fascinating and thoughtful panel discussion. Also, a special thanks to Dr. Khan to just engaging with our speaker to unfold many such issues. And we enriched from all the thoughtful and insightful perspectives provided by our esteemed speakers. I would also like to thank my prospective teams and all my participants to make our program successful, and we look forward to all of you in future also. Thank you.